Welcome back to another clinical toxicology video for health science students. I'm Dr. Suchard, and this time we'll be discussing digoxin-specific antibody fragments, corresponding to antidotes in depth chapter A22 in Goldfrank's Toxicologic Emergencies. The learning objectives here are that you'll be able to identify indications for using digoxin-specific antibodies as an antidotal therapy, and to outline the dosing regimen, which is to say how many vials to use, based on the ingested dose of digoxin, or a serum digoxin level, and when the antidote is used empirically in cases when such information is not available. Digoxin-specific antibody fragments are made from sheep antibodies. Sheep are immunized so that they'll make antibodies against digoxin. The resulting antibodies are isolated from the serum and treated with the enzyme papain, which splits the whole IgG into two Fab fragments, each of which combine to digoxin, and the Fc portion of the antibody, which is the portion most likely to provoke an immune response if given to non-sheep species like humans, so it's a good idea to remove the Fc portions to make a safer product. Then the Fab fragments are lyophilized, basically they're freeze-dried and packaged up in vials. At the time of this recording in 2023, there is only one digoxin antibody fragment product on the market in the US called DigiFab, whose trade name should now be self-explanatory. You may find references to another virtually identical product from a different manufacturer called Digibind, although that was discontinued in 2011. Fab fragments are given intravenously, and when you give a digoxin-specific Fab antibody fragment, it's going to bind up digoxin. Fab fragment therapy rapidly reduces the free serum digoxin levels below detection limits. The digoxin is still there, it hasn't been cleared from the body, but now it's bound to a Fab fragment in the intravascular space and inactive, instead of binding to sodium-potassium ATPase in the tissues causing toxic effects. Thus, the Fab fragments cause redistribution of digoxin from the heart and other tissues. While the free digoxin levels will now be roughly zero, most labs can't measure free digoxin. If you order a digoxin level assay from the lab, you'll get a total digoxin level, and that total digoxin level will now go up several-fold since the Fab fragments are effectively pulling the digoxin from other tissues into the blood. Digoxin-specific Fab is indicated for life-threatening or potentially life-threatening cardiac glycoside toxicity. This toxicity may be from various cardiac arrhythmias, including both dangerously slow and, maybe more frighteningly, dangerously fast varieties. Since cardiac glycosides block sodium-potassium ATPase, this blocks the pumping of potassium into cells. A patient with enough systemic toxicity will become hyperkalemic. If we are attributing hyperkalemia with a potassium level above 5 milliequivalents per liter to cardiac glycoside toxicity, that in itself is an indication for treatment. In the days before digoxin-specific antibody fragments, many dig-toxic patients with potassium greater than 5.5 died, while most with a potassium of 5 or below would survive. Patients with large acute digoxin ingestions should also be treated, and we probably wouldn't wait for them to show severe signs and symptoms. What's a large acute ingestion? At least 4 milligrams in kids and 10 milligrams in adults. The dosing of DS-Fab can be based on the acute ingested digoxin dose when known. With an acute overdose, you might order a serum digoxin level, but the treatment decisions shouldn't be made based on it. The level may still be rising, and it certainly hasn't equilibrated, because there hasn't been enough time for it to be distributed through the blood and into other tissues. It is known, though, that each 40 milligram vial will bind to 0.5 milligrams of digoxin. So we can make a calculation of how many vials to give. You take the amount ingested in milligrams, multiply that by 0.8, which is the oral bioavailability of digoxin, and divide that by 0.5 to give you the number of vials to administer. When there is chronic digoxin toxicity, in the absence of an acute overdose, we are more confident that the serum level is near equilibrium and helps to predict the total body burden. So we can take the patient's serum digoxin level in nanograms per milliliter, multiply that by the patient's weight in kilograms, and divide that by 100 to give us the number of vials of DigiFab to administer. Some additional dosing considerations. There may be cases where the acute ingested dose is not known, or cases where we know or highly suspect the patient has digoxin toxicity, but we don't have a serum level yet. In cases of empiric dosing, it's recommended to give 10 to 20 vials for acute toxicity, and lower doses, as shown here, for chronic toxicity, depending on the size of the patient. And if there's a case of non-digoxin cardioactive steroid toxicity, It's almost definitely going to be from an acute ingestion, so you just give the same empiric dose as for acute digoxin toxicity. That's all I've got for you regarding digoxin-specific antibody fragments. I'll be seeing you around.